All right, welcome everyone to this webinar this Sunday evening in New Delhi. And it's 2 p.m. in Nigeria, West Africa, and it's 8 a.m. Central Time in Texas, United States. Thank you for joining us from around the world. We are privileged to have Dr. Saumya Saluja in the house today, a specialist periodontics and oral implantologist all the way from New Delhi, India. Dr. Saluja, welcome to Dental Webinar Series. Thank you for accepting our invitation to present on a very, very important topic, peri-implantitis. I want you to just introduce yourself and take it away. Please do send messages to your friends. This is an important topic. And we'll hear more on this from Dr. Saluja. We didn't hear about peri-implantitis until you will have it. Once you start placing implants, then then you're just in line to get some of all this. But there are ways to correct it. There are ways to prevent it, and we're going to learn more about it. Dr. Saluja, welcome to the program.
Thank you so much for such a warm welcome, Dr. Uvo. And I think I would want to start this discussion by simply thanking you for this wonderful opportunity and meeting a lot of people. And to all the listeners and the viewers today, thank you so much for your precious time. And without wasting any more time, I'm just simply going to delve into the topic. Uh, most of us might be thinking, why have we selected this topic of peri-implantitis in the first place? Well, peri-implantitis is very close to my heart. It's just discussed with Dr. Uvo today. And what I personally feel is that all implant surgeries, they may not succeed, or they just might lose, the implants just might lose their lives in the long run. So what could be the possible reasons of these implant failures eventually, or maybe immediately? Uh, there could be patient related factors, there could be surgical factors, and there could also be social factors. Well, in my case and in my experience, I had all of these factors together. So one must always, learn from your circumstances, your experiences. It's very important that we learn from our mistakes. We learn from the experiences that we've just had. So what I have learned from my implant surgery so far and my implant surgery journey so far is that it's important to just have an effective communication with your patient. Always establish a very, very strong, doctor-patient rapport so that your patients would have realistic expectations. They would not be unrealistic, or they would not, the expectations would not be overwhelming. That would pressurize the practitioner, right? So, on that note, let's understand the failures that we usually encounter in implant therapy. And I'm going to start with the definition. This is very basic, that what is actually referred to as an implant failure. Well, an implant is considered to be a failure if its signs and symptoms, they start appearing, or when an implant requires a removal within the first year of its insertion. Now, this could be, during their early phase of healing, or this could be immediately after implant loading. Now, based on these, the implant failures can be early or they can be late implant failures. Early implant failures, they usually occur following the installation of the implant. This could be due to the improper preparation of the recipient site, which hampers, the heart tissue, that is your bone. That can actually lead to bone necrosis. Then we have bacterial contamination. Bacterial contamination can lead to extensive inflammation at the wound site, and this delays the healing of your soft and hard tissues. Then, improper mechanical stability of the implant, and finally, premature loading of the implant. That is when the osseointegration is not being completed. Now, the late failures could be when the implant is in function for various periods of time. Now, this could be due to excessive load that leads to result in implant mobility. Now, this is one of the most important factors that we'll be, that I'll be covering in the upcoming slides. And of course, the implant infection. If the patient doesn't follow proper oral hygiene instructions or the recommendations by the practitioner, it's impossible to maintain a good implant. Now, based upon these causes, the implant failures can be classified into the ailing, failing, and failed implant. This also determines our clinical or the surgical intervention when we are dealing with peri-implantitis, right? So the ailing implant is a condition where implants, when they exhibit soft tissue problems, they are exclusively referred to as ailing implants, and these have a more favorable prognosis. Failing implants are the ones where the bone is involved. That is, when the implant is associated with progressive bone loss, but is still clinically stable. That is, we can still save the implant with the surgical intervention, because I'm repeating, the bone is involved. Now, finally, the failed implant. When plant or the implant mobility is excessive and there is bone loss beyond 70%, in such cases, we do not save the implant and we finally declare the implant has been failed. Another important thing is, now based on these things, the implant the implant failures can also be classified based on their causes, the condition, the timing of the failure mode, the supporting tissue type, most importantly, and their origin. So in this presentation, I will be dealing with the implant failure based on the origin, that is peri-implantitis. Okay, so as I've just discussed, that the implants are influenced by the tissues around it. We've talked about the soft tissues, surrounding the implant. We've talked about the hard tissues surrounding the implant. So when we talk about the implant failure, we must talk about two terminologies. And before discussing these two terminologies, I would like to discuss the meaning of the word peri-implant. Peri-implant is basically prefix that is used to describe the tissues which are surrounding the implant structure. So in this context, we deal with two major terminologies. First would be peri-implant mucositis, and the other is peri-implantitis. Now, but the definitions would automatically define that where do we mean that the implant is an ailing implant and when the implant is a failing implant. Okay, so peri-implant mucositis, it is actually the inflammation around the peri-implant tissue without bone loss. This is actually a reversible inflammatory reaction, which can be where we actually, manage the mucosa surrounding the implant. Peri-implantitis obviously would involve the bone. Now here the marginal bone is most commonly involved, and after this, once the marginal bone is involved, if the condition is not detected early, the surrounding bone, other than the marginal or the crestal bone, it is rapidly involved, and if we do not evaluate it by using a radiograph, the implant can fail. So this is about peri-implantitis. I'm still reading the definition, that it is an inflammatory lesion that differs from mucositis because a marginal bone loss occurs and it progresses diagnostically by a radiograph. Now, what are the possible risk factors which are responsible for peri-implantitis? First would be a traumatic surgical technique. The surgical technique is of utmost importance here. We have to be very precise when we are placing an implant. Then patient's previous history of periodontal disease. If the patient already has a history of bone loss and the patient has a history of periodontal pockets, or let's say recession, then there is a very less chance that this implant would survive for a very long time. Habit of smoking. This is a personal experience that I had a patient who had a chronic habit of smoking for the past 20 years. Well, after taking all the steps, the implant did not work in that case. Then inadequate amount of host bone, which is of utmost importance again, the bone has to be there. Then poor oral hygiene, diabetes, again, and genetic factors. So the prevalence of this peri-implantitis is somewhere around 14.3.8 to 24.27, which has rapidly increased. From about 5 to 10% that used to be 2 decades ago. And apart from the patient or the surgeon related factors, there are also implant associated factors that can cause peri-implantitis, and these include the implant designs, the surface characteristics of the implants, and the period of implant function. Period of implant function, again, I'm referring to the heavy masticatory forces or the improper abutment placements, which can actually hamper or which can actually lead to the implant failure eventually. And for understanding, the concept of peri-implantitis, it is very important to know the concept of excessive load. Now, the high stresses or the multiple fractures in the coronal bone to the implant contact, it leads to loss of osseointegration. Now, this will actually be a major contributing factor which will cause implant failure. Why? It will cause trauma from occlusion. So, implant which is placed in a poor quantity of bone, or the implant position or total number of implants which do not favor, the ideal transmission of the load, the masticatory load over the implant surface, and the patient's habit, the bite of the patient. If the bite of the patient is heavy, or the parafunctional habits have been detected or diagnosed, such as bruxism, all of these can lead to implant failure. And of course, prosthetics superstructure does not fit the implant precisely is a very obvious factor. So now, how do we diagnose peri-implantitis, which again is a very important factor? So we'll just learn the clinical examination, the radiographic examination, and then finally the management of all of these. And of course, the occlusal examination also is very important. That would actually help us determine whether the patient might develop TFO eventually, or has already heavy masticatory forces, which may not be favorable for the success of the implant. And before that, I would just simply like to discuss the key landmarks, which are very important for the clinical examination of peri-implantitis. Now, you can see that this image, it has two halves. The first one is the tooth. The second half represents your implant, right? So, I'm not going to go into the details, but just the basics. First, I'm going to define what is the biological width. Now, biological width, it is the established distance between your junctional epithelium and the connective tissue to the bone. So this is a very important landmark, and this has to be maintained both in a healthy and an implant or an inserted implant case, right? So just as in a healthy tooth, we have oral sulcular epithelium, we have junctional epithelium, and we have oral epithelium. Whereas in case of an implant, we have peri-implant sulcular epithelium, we have peri-implant epithelium, and we have oral epithelium. In case of an implant, the biological width is usually measured from the sulcus that I'll discuss in the upcoming slides. Another picture, now this is just a slightly magnified image to what we've just seen. I'm not going to get into the details again, just to make sure that these key landmarks that we just studied, they fall between this distance. This is the shoulder of the implant, and this is the first bone to implant contact. So all of these key landmarks, they fall between these two structures. Baki, the junctional epithelium, it has its coronal junction, it has its apical termination, then we have the connective tissue, and we have a biological width. Again, we measure in case of an implant from the. So now, what are the differences? Sorry. Now, this is the basic tabulation of the structural differences between the implant and our tooth. So the tooth is in a normal case or a normal tooth is connected to a bone by the periodontium, such as the periodontal ligament, we have the cementum and the bone. In case of an implant, we do not have a periodontal ligament. We simply have osseointegration and we have the bone functional ankylosis. Then the junctional epithelium. The junctional epithelium in case of a tooth composes of the hemidesmosomes and basal lamina. In case of an implant, the basal lamina has three sublayers. One of the addition would be the sublamina lucida zone. The connective tissue have 12 groups in the case of in case of a tooth. In case of an implant, we have only two groups: the sulcular and the parallel. Biologic width, like I just mentioned, that in case of an implant, we would include the sulcus, which would be slightly higher in case of a tooth. Vascularity of a tooth would obviously be higher than an implant. The probing depth of a healthy tooth is usually 2 to 3 millimeters. We do not go beyond 2.5. 3 millimeter is the maximum, depending upon the patient, depending upon the case. In case of an implant, it usually is 2.5 to 5, but again, the rough estimation is from 3 to 4 millimeters. Bleeding on probing, that we'll be discussing in the upcoming slides, is more reliable in case of a tooth and not in case of an implant. So, what exactly are the clinical indicators or the clinical indicators, or let's say the characteristics of the soft tissue? Firstly, you must know the normal the normal characteristics of the soft tissue: the color, the contour, the size, the consistency, the surface texture, everything. So I'm just going to talk about gingiva here, which because the surface changes would be the clinical parameters would be gingiva based, right? So the color has to be coral pink in a normal case. The contour is scalloped. The size has to be normal. The increase and the decrease is very, very clearly visible. The consistency has to be firm and resilient. If it is absent, if it's smooth, then of course it's gone. And the surface texture, it has to be stippled. So these parameters, they should always be noted and they should always be compared with the baseline records. That is, once we have placed the superstructure, once we have placed the prosthetic appliance, before that you must have a basic parameter reading so that we can compare with the future lyrics. Right? So, the clinical examination involves your bleeding on probing, the suppuration or the pus formation. Then we have the probing depth, which should be greater than or equal to 6 millimeters. Remember, it was up to 5. Beyond 5, meaning the soft tissue inflammatory lesion has started to develop. Then there is loss of supporting bone. That should be that should be greater than or equal to 3 millimeters, and implant mobility, which is a very, very obvious sign of implant failure. Bleeding on probing. Bleeding on probing usually reveals the presence of an inflammation. So, in case of peri-implantitis, it has been found to be a very poor predictor. However, its absence could be, it may be a good negative predictor of attachment loss. So, bleeding on probing should be checked just to check whether the attachment loss has been affected or not. Now, this is a very clear picture showing peri-implantitis. Here, the bone contact has started begun, whereas in case of a healthy tooth, if you can see that the gingiva is coral pink, the tissue is firm. Here in this case, the tissue has become soft, it is slightly reddish, and we are reaching the bone. Then suppuration. Suppuration is not very difficult to identify. It indicates active tissue destruction and necessitates anti-infective therapy. We will be discussing about all those therapies in the upcoming slides again. Probing depth. Probing depth, I would say, is the most reliable diagnostic parameter. So successful implants, they do not allow a penetration of more than 2.5 to 5 millimeters. If the probing depth is above 6 millimeters, that means the disease condition has started establishing itself. This is the classic method of measuring the probe, of taking on the probing depth. Okay. Now, peri-implant probing is is usually a very debatable topic. However, we should not ignore that the baseline probe readings, they should be recorded at the time of prosthesis delivery and before the appliance is seated in the patient's mouth. But if there is absence of pain, there's absence of discomfort or other clinical signs of the disease, the value of probing is usually, it may be questioned. So it is important that the clinical judgment should be made or should be used in determining the need for probing. If the patient is not, if the patient is not complaining, then ideally we shouldn't be probing unnecessarily. However, if we see some clinical signs that are developing, probably patient might not tell us all of those about those signs. So it is better that we take on those clinical readings by ourselves. Now, the force that should be applied here, it should be relatively lesser. Reason being that the periodontal ligament is absent. So the force should not be more than 0.2 to 0.3 newtons, and because it has been found that the probe, it causes a separation between the surface of the implant and the epithelium that can actually fail your osseointegration and ultimately lead to failure of the implant. Now the difficulty would arise in case of multiple abutments. When multiple abutments are connected, by a prosthetic superstructure, so the probe readings, they may be difficult because of the access problems in positioning the probe tip parallel to the long axis of the transmucosal abutment. So in such cases, we use flexible plastic probes. This is a picture of a flexible plastic probe. Okay. And the most accurate readings, they are usually obtained when the suprastructure is removed, which may not be possible every time, but if it is, one should. Now coming on to the most important clinical examination here, which is your implant mobility. That is, after the soft tissue has been assessed and documented, the presence or the absence of mobility of the implants, the transmucosal abutments and prosthetic superstructure, it should always be evaluated. Because sometimes we do not know that maybe the soft tissue changes are not appearing on the surface, but there is rapid bone loss going on within the at the implant site. So this can lead to implant mobility and ultimately implant failure. And implant mobility cannot, be understood without understanding two basic terms here. First is rigid fixation, and next is osseointegration. They're both synonyms, but rigid fixation is the term that we use for the clinical that we use is for the clinical mobility of an implant when the clinical mobility of an implant is tested, whereas osseointegration is more of like a histological term. So the term rigid fixation is used to describe the absence of clinical mobility of an implant when it is tested with both vertical and horizontal forces. The forces should be less than 500 grams. However, osseointegration is a histological term that describes a direct bone to implant contact at the level of magnification of light microscope. So this cannot be clinically seen, but if rigid fixation is absent, the chances are very high that osseointegration is used. Many clinicians, they routinely remove the prosthesis yearly to definitely test for implant and abutment mobility. Why? Because successful osseointegrated implant has no periodontal ligament. Periodontal ligament is a very important structure of a normal tooth because it acts as a shock absorber, it acts as a, it has a cushioning effect. So this is responsible for taking up and this basically helps in equal dissipation of forces, of the occlusal forces throughout the oral cavity. So in case of an implant, if the periodontal ligament is absent, then the chances are very high that the occlusal loads would lead to implant failure. So therefore the abutments, and especially the multiple abutment cases, in case of a multiple abutment superstructure, it is very important that the mobility of the implant needs to be checked time and again. So zero mobility is anticipated around stable implants. Again, the implant mobility is incomplete without radiographic examination. So one of the most valuable measures in assessing peri-implant alveolar bone levels is your radiographic examination, which is usually less sensitive in detecting early pathology. So for that, we have to, rely on our clinical findings. Whereas, uh, however, once we have placed the implant, the post-operative radiograph is taken immediately. That we all do after implant placement, after the implant is placed to verify the position of the implant, and it also establishes a benchmark for future comparisons. So radiographic examination is very important post-operatively and for the maintenance phase. Okay. So, further imaging requirements are obviously based on the clinical situation of the particular patient, but we still have certain intervals which are recommended in the absence of obvious clinical problems. So, this should be done after the first, third, and the fifth years of the implant placement. Now, some common causes of rapid bone loss. First would be the associated fractured fixtures. Then we have the initial osseous trauma during insertion. Then we have stress concentrated at the marginal bone by over tightening of fixtures during the placement. Trauma from occlusion, yes. Poor adaptation of prosthesis to abutment, very important again. The normal physiological bone resorption. If that is hampered because of some medical condition, again it will lead to implant failure and rapid bone loss. Then plaque associated infection. If there is a microbial plaque formation around the implant surface, particularly between the implant flutes, then that area is hampered, and it will lead, then that can also lead to the bone necrosis and ultimately implant failure. So which radiographs should we choose for checking this, for examining this bone loss? First, the most common ones that we use are standardized IOPAs. In case if we have digital RVGs, they are even better. Panoramic images usually, it is recommended when we have to examine the horizontal bone loss. And finally, CT scan can also be used in particular cases. Now, how do we interpret, that the implant has started failing? Okay, so now these failing implants, they exhibit a thin radiolucent space that may mimic, normal periodontal ligament space, and it creates a saucer-like defect around the alveolar crest. Moreover, always check the periapical region, this particular region, for any significant radiolucency. So the alveolar crest and the periapical region, both of these are of paramount importance when we are checking for periimplantitis. Again, as I just mentioned, that there is no maintenance phase of for the implants without checking for trauma from occlusion. So the occlusal evaluation is very important. Because the and this is why occlusal evaluation is important, because the periodontal ligament, it precludes the ability of the tooth to absorb any excessive loading. So occlusal trauma of any magnitude from the prosthesis, of especially very high magnitude from the prosthesis, that could negatively influence the surrounding supporting structures, they may affect the implant, and they may lead to their failure. So how do we check that the implant is failing because of the occlusal problems? First and foremost, the abutment screws would loosen up. So the loosening of abutment screws. The implant would ultimately fail because there will be obvious implant mobility and prosthetic failure. Yes, because the heavy masticatory forces would rupture or would affect the prosthetic appliance that we would be giving to the patient, and this would ultimately lead to implant failure. So the occlusion should be evaluated at every maintenance appointment. Okay. And what can be done to correct these occlusal issues? First, any signs of occlusal disharmony, such as premature contacts or interferences, they should be identified and corrected as per your convenience, as per the patient requirements. then the implant protected occlusion should have light-centric contact with no contacts on lateral excursions. The implant prosthesis should be examined when the patient has been diagnosed with bruxism or parafunctional habits such as tongue thrust. Again, as we just mentioned previously, that the periodontal probing or the probing depth it becomes questionable in the absence of any clinical or subjective signs. So I would say that yes, your subjective signs, they do have a role to play in. So it is important to establish that rapport with the patient. The patient should discuss any discomfort or any functional inability at each maintenance appointment. Please do talk to your patients. Pain or discomfort, they could be the first signs of a failing implant, and such cases usually present with mobility as well. So there may be also there could be associated radiographic changes, or we can or sometimes you also come across fractured or loosened screws, which should be the first suspicion when the patient complains of a loose implant or any discomfort. Coming on to the managing part of peri-implantitis. Treatment or the management of peri-implantitis, it usually has been divided into three major categories. The first one is the non-surgical management. Non-surgical management includes the mechanical debridement and the adjunct use of antiseptics and antibiotics. Coming on to surface decontamination. Surface decontamination is usually used for the implant areas where our mechanical instruments are unable to reach. And this can be done by chemical methods and lasers. Coming on to surgical treatments. Surgical treatments involve the air power abrasives, the resective surgery, and the regenerative surgeries. So we're going to deal with each of these individually. Starting on with the occlusal analysis. So any treatment depends upon the examination of the occlusion. Okay, so very simple. Occlusal analysis can always be corrected by checking the fit of the prosthesis. If the prosthetic design changes are required, we require to improve the number of the implants or the position of the implants, or occlusal equilibration, which would help in equal distribution of the forces. All of these, if they are corrected on time, then the progression for the implant failure can be protected without any non-surgical or any surgical intervention. Coming on to the non-surgical management. What are the indications for non-surgical therapy? Like I just mentioned before, that non-surgical therapy is strictly for the mucosal inflammation, where we say that the prognosis is fairly good. The implant is at an ailing stage. The radiographic evaluation of the bone levels should be checked before starting or before finalizing the non-surgical therapy for your patients. So this non-surgical part, it involves mechanical debridement. So what do here is we reduce the soft tissue inflammation by removing the microbial plaque on the implant surface. And here the mechanical instruments that we use, they involve the plastic curettes, we have ultrasonic scalers, we have metal curettes, then we have metallic brushes or titanium brushes, and we have piezoelectric scalers and other hand instruments. But this is a classic picture. Here you can see that this is a plastic curette and this is your titanium brush. This can be used for mechanically cleaning the implant surface. Now, as I previously mentioned, that the antiseptics and the antibiotics, they are usually used as an adjunct to your mechanical debridement. So, I'm starting with the antiseptics first. These are used as local irrigators. The most common ones that we use are 0.12% chlorhexidine gluconate, and it is effective in reducing peri-implantitis. It could relieve a couple of symptoms but will not be a complete treatment without mechanical debridement. Mechanical debridement is a must. After that, we have is antibiotics. Antibiotics are again to combat infections. They work either by killing or by inhibiting the infectious agents. So the most common local antibiotics that we use are minocycline, doxycycline, gentamicin, and cefazolin. Of these, minocycline and doxycycline I've personally used, and they are way better in comparison to gentamicin and cefazolin. So the antibiotic therapy, it can enhance the body's ability to fight off infections in case of a subgingival pathogen that may even persist after the mechanical therapy has been performed. So we usually use a combination of local and systemic antibiotics, which may offer a greater spectrum for treating peri-implant infections. Another technique or another methodology that we can use along with the mechanical debridement is the use of antimicrobial photodynamic therapy. Now, this involves the use of 200 micrograms per milliliter of methylene blue under the red laser irradiation, and this only helps in surface decontamination of the implant surface, but it's still an upcoming technique, so we must know about it. However, antibiotics and to a certain extent even the antiseptics are a way better option over the photodynamic therapy. Then coming on to the surface decontamination part. As I just mentioned, that surface decontamination involves the chemical surface decontamination and it involves the use of laser. So let's just start with what exactly is this surface decontamination? Why are we actually using it? So it is a non-surgical mechanical. Non-surgical mechanical therapy is effective for ailing or in cases of peri-implant mucositis. But sometimes but it usually fails. The mechanical therapy fails when the implant surface is exposed. So, so therefore, in such cases where the mechanical instruments are not able to reach and we are not able to completely remove plaque due to limitations in accessing the spaces between the implant threads with traditional instruments. And now this is where the surface decontamination it comes into picture. So first, it is used for the exposed implant surfaces which has already been exposed to the microbial plaque, and it would help us in reaching out to the non-accessible areas between the implant threads. So we have two major solutions now. So I'm starting up with citric acid. Citric acid is a very common cleaning implant agent, and it has the highest potential for removing biofilm, but it does not guarantee complete removal. Whereas ethyl diamine tetraacetic acid, it is one of the most commonly used chelating agents, and it actually helps in removing the smear layer, in periodontal, and it helps in periodontal regeneration and peri-implantitis. But the studies have shown that it can cause cytotoxic effects. So it is recommended to use EDTA with a lot of caution. Another strong agent that we come across in dentistry is hydrogen peroxide. Now, hydrogen peroxide, though it helps in reducing a large number of bacteria and fungi, but if high strengths of hydrogen peroxide are used for prolonged periods of time, it can be extremely reactive and can actually harm the surrounding oral tissues. So again, it is not a very viable option for the soft tissue as far as the soft tissues are concerned. Saline solutions. Now, saline again is one of the safest solutions that we use in dentistry, but what we see is that the use of saline with curates, it could provide stable outcomes, but it would not completely treat peri-implantitis. So, surgical debridement with the curates, followed by rinsing with sterile saline, along with post-operative antibiotics. All of these they help in the reduction or controlling of the peri-implantitis symptoms. Moreover, if salines, more some chemical agents are added to normal saline solutions, it may enhance its ability to decontaminate the surface. Again, there is no conclusive evidence to it. So normal saline is a stable, it is a safe agent, but it is not very effective in removing the microbiota around the implant surface or the infected implant surface. Okay, the next are the lasers. Lasers, again, what does a laser do first of all? Lasers usually ablate, the infected tissue area, and then that treated area, it undergoes healing, right? So the simulated radiation emission can be used as a surface decontamination technique just to support the conventional mechanical therapy here. Moreover, it has better. It is more. The patients find it more comfortable, and there could be pain relief, immediate pain, and there could be pain relief when we use lasers. And the most common lasers that we use for peri-implantitis are diode lasers, carbon dioxide lasers, and the erbium doped yttrium aluminum garnet lasers. Coming on to the most important intervention for peri-implantitis, this is surgical management. So once we have clinically diagnosed the condition, we have seen the occlusal examination. Once we have checked the occlusal examination, we have checked onto the radiographic evaluation. We have come to the conclusion that the case needs to be surgically intervened. Then here we are going to learn some of the basics. First is, what is reosseointegration? Reosseointegration is one of the most important terminologies that we must know before we surgically intervene a case of peri-implantitis, right? So what is reosseointegration? It is the growth of new bone in direct contact with the previously contaminated implant surface. So one must make sure that the growth of a new bone starts with the previously contaminated implant surface without an intervening band of organized connective tissue. And for that, it is very important for us to know the various types of osseous defects. Uh, Group 1, 2, 3, and 4. So all of these would have a common case of horizontal bone loss, right? And group 1, apart from having a moderate horizontal bone loss, there will be minimum intrabony component involved. Group 2, moderate to severe bone loss, again with a minimal intrabony component involved. Group 3, minimal to moderate horizontal bone loss with circumferential intrabony lesion involved. And last, more complicated implant effects, or we call them the combined effects, where horizontal bone loss and circumferential bone loss both are combined. I'm just going to explain them with the help of these pictures. Now here, this is a buccal dehiscence. As you can see, these are all intraosseous lesions. We can see minor bone loss. This particular picture shows two bone walls involved. This can be very well radiographically appreciated, or once we are surgically intervening, we can appreciate these signs. Circumferential, that is all around the bone. This is a classic horizontal bone loss case. Buccal dehiscence along with horizontal bone loss. Then 2 to 3 bone wall defect with horizontal bone loss, and advanced circumferential with moderate to severe horizontal bone loss. Now all of these cases, these are our combined complex lesions, these actually necessitate a surgical intervention on immediate basis. Now, as I previously discussed, that surgical treatment involves AFR abrasives, we have resective surgeries along with implantoplasty and the regenerative surgical work. So how do we proceed for the surgery? Now, this is once we have decided that that we are going to perform a surgical procedure for correcting the implant work. So, what should be my approach? First is we have the access flap and we mechanically deep bride the case, and then based on the type of bone defect we decide whether we want to contour it or we want to go for a regenerative approach. The air abrasive powder here, in this case what we use is sodium bicarbonate or calcium phosphate or glycine amino acid. These are all propelled by compressed air to effectively, remove biofilm and clean the contaminated implant surfaces. But this particular air abrasion debridement, it can effectively remove the bacterial biofilms, and it can cause microscopic damage to implant surfaces. So we do not perform air abrasive powders procedures that much. Coming on to resective surgery. Now, what exactly is resective surgery? Resection in general means that we remove the infected section or we remove the affected organ, right? In case of a bone, resective basically means correcting or recontouring the affected area. Now, this resective surgery, it aims to reduce the pocket depth by utilizing either osteoplasty or ostectomy. Ostectomy means cutting, osteoplasty means correcting the osseous defect and allowing better flap adaptation. Then this can be performed along with implantoplasty. I'll be discussing implantoplasty. So the use of whenever we combine resective surgery with implantoplasty, we use the apically positioned flap, and which is usually effective and reliable. Then it should be noted that increased gingival recession, it may limit its use in aesthetic areas. So where do we use or where do we perform these resective surgeries? When there is again moderate to severe horizontal bone loss, when when more than one wall or 1 to 2 wall defects are involved, and implant position is in the anesthetic zones or the anesthetic areas. Coming on to implantoplasty. Implantoplasty is referred to as fixture modification. It is a procedure that involves the elimination of an infected and exposed implant surface. So the primary objective is to decontaminate the infected implant surface and obtain a smooth surface which reduces plaque adherence. So it is performed alongside resective osseous surgery, again utilizing an apically positioned flap. Now, these are some of the pictures which show that how do we perform implantoplasty. As you can see here, we have simply decontaminated the implant area. So this does not involve the bone. This is a reconstructed area where we are simply decontaminating the implant surface and slides moving, just correcting it here. Now this is implantoplasty during combined treatment of peri-implantitis. Here the bone is involved. How implantoplasty is formed. Now this procedure involves a high-speed diamond bar, which removes the infected implant threads, followed by an Arkansas bar to polish the surface. So the procedure involves not only removal of the infection but also polishing of the implant surface so that plaque does not adhere to this smoothened surface. So these bars have been found to be the most effective in creating the smooth implant surface, and this usually is performed along with ostectomy or osteoplasty, like you've just seen. In one of the cases, we have performed osteoplasty, just correction of the bone contour, or ostectomy where we have removed the infected bone. The disadvantages are, firstly, it would actually leave metal debris, which could be cytotoxic, it could be genotoxic, which are released from the implant, because we are cutting off the implant surface. So that can actually lead to adverse effects. Then the extent of these harmful effects depend on the physiochemical properties and concentration of the debris also. So therefore, we must use rubber dams and bone waxes to protect these tissues during the procedure. Additionally, it is important to note that implantoplasty may weaken the implant abutment, the connection, particularly in implants with a diameter less than 3.75 millimeters. So when performing implantoplasty, it is important to exercise caution when working with narrower and single implants, because they might be subjected to higher occlusal load. So implantoplasty has to be performed with a lot of caution. Regenerative procedure. Regenerative procedure, it promotes growth bone growth in areas which are affected by peri-implantitis. And this can be achieved through the use of the bone grafts, either with or without membranes, or through the use of biological agents such as growth factors or bone morphogenic proteins. So what are the indications? This can be performed for submarginal regenerative therapies and pergingival regenerative therapies. So here, submarginal includes the moderate to severe circumferential intrabony defects, which are very important. Then these can always be used for detoxification of implant surfaces and implants which allow complete closure of the flap. Complete closure, so that your bone graft doesn't move from its position. The membrane that we use, it doesn't move from its position. Then for the pergingival regenerative therapy, it is usually used for one-stage implants or non-retrievable prosthesis. Then we have moderate to severe circumferential infrabony defects, three-wall bone defects, and finally detoxification of the implant surfaces. So both of these they can be performed as per our requirement and as per the patient's requirement. What are the limitations? Now, in case of peri-implantitis, where there is significant amount of bone loss, the chances of success are very low. See, whenever we decide that we want regeneration of the bone, already the chances have reduced. And that's probably our last resort to save the implant. Once we decide that the regenerative procedure will not work, that means that the bone loss has crossed the limit of 70% or let's say 60%, 60 to 70% usually, and that means the implant is going to fail at any cost. So there's no point saving that implant and wasting time. Then improperly positioned implants, even after proper bone remodeling or regenerative procedures, can potentially kill the success of implant surgeries. And the mobility of implant, as I just said, that the bone loss has increased, there is no chance that we can save such implants. Reason being, the osseointegration has already been lost. Another important thing, that whenever we decide that we want to perform a particular surgery, or we want to, we actually are going to pick up a certain management procedure for saving the implant surface plays a very important role. How? Why? Because the implant surface is obviously involved in the defective area, right? So the surface of the dental implants is usually a topic of debate. Implants coated with hydroxyapatite, they have shown to have ongoing phagocytosis, but further clinical and histological studies are necessary to fully understand their effectiveness. Titanium implants, they have demonstrated minimal to no resorption. So once the inflammation around the titanium implant has been controlled, the surgical intervention could be considered. Whereas if we have coated or we have hydroxyapatite surface coated implants, in such cases, uh, even the regenerative procedures may not work because the level of resorption would comparatively be higher. Now, the most sad part of all of this, that in spite of trying everything in the book, if any of these procedures do not work, what are the possibilities when the implant should be removed? Okay, improperly positioned implants, where we've discussed that regenerative procedures would fail. Then, if an implant becomes mobile, yes, when there is excessive bone loss. When the bone loss involving implants, it reaches out to the vents or holes. Unfavorable advanced bone defect, that is the severe horizontal bone and the circumferential bone losses, all of this. Rapid and severe bone destruction within the first year of loading is very important. It should be considered. Therefore, please talk to your patients, have an effective communication. Probably implants will not work in such patients. Non-surgical or surgical therapy, if it is ineffective, obviously the implants will fail. Aesthetic area providing implant surface exposure, the implant has to be removed. So, um, in case you have to remove the implants and replace it, so please use, it is recommended to replace it with a larger diameter implant during the second procedure. Now, Being a periodontist, it's very important that I just said that you must have, a proper doctor-patient rapport, and you must talk to your patients. But it is very important to keep on counseling your patient for proper at-home care of your implants. Implants usually fail if patients do not maintain a proper oral hygiene. So, just a few tips on that. Because the role of a patient is of a co-therapist, so it is important that patients should understand their responsibility in taking care of their implants, right? So uh, the patient's motivation and skill in performing oral hygiene methods, it usually influences our prosthetic design, and of course it would decide, or it would actually help us in determining the life of the implant surgery. Again, dental professionals, please, you play a very important role in assisting your patients. Maintain an adequate oral hygiene level. We have a variety of clinical cleaning methods on depending on the type and the design of prosthesis that I'll be discussing in just a few slides. Firstly, recommendations after after a two-staged implant surgery. After the first 24 hours of the implant surgery, once they have followed all the instructions properly, please do ask your patients to rinse their mouths with salt water. We call them warm saline rinses, twice a day at least until the tissue swelling subsides, but only after 24 hours of surgery. Then we usually give them, a prescribed chlorhexidine rinses that should be not less than 30 seconds for at least 1 week after stage 2 surgery. So this would prevent and this would help them maintain better oral hygiene. So, because tissue healing, is usually hampered by the microbiota or the plaque film formation in the mouth. So, both of these, the warm saline rinses and chlorhexidine rinses, they would help us in reducing the microbiota accumulation in the mouth. Now, a soft tissue brush. A soft tissue brush or an end tufted brush is used in addition to rinsing. That should always be done again after first 24 hours. We usually don't allow patients to brush immediately, alongside the surgical site. Please do not, the bristles can actually hamper the surgically excised tissue. Please do not touch it. Then the gentle brushing is important because patients may experience soft tissue sensitivity for a period of time after the surgical procedure. So again, soft tissue brushing is recommended even after the surgery has, even after 24 to 48 hours. Patients can always use, their toothpaste with the help of their fingers around the surgical intervention. Okay. So recommendations for complete and partially edentulous patients. Now, as you can see here in the pictures, that a standard toothbrush is usually recommended for their facial, the lingual, and the occlusal surfaces of the prosthetic suprastructure. And a nylon coated interdental brush is effective for plaque removal of the proximal surfaces of a button. Another important thing here is that a flat end tuft brush on the facial surfaces, a tapered end on the lingual surfaces, and usually a cotton swab with a prescribed topical applicant is used to clean the abutment cylinders. These are your. So please remember that the prosthetic bridge design and patient dexterity, they dictate the selection of the type of floss or flossing cord. Flossing cord specially designed for dental implants that polishes the transmucosal abutments and gingival site of the prosthesis. Rotary brushes may be helpful adjunct to home care regimens. Then recommendations for single teeth. Okay. So this depends on the prosthetic and the abutment design and its location in the mouth. A soft toothbrush is recommended for brushing the crown and the prosthetic part surrounded by the gingiva. Nylon coated interdental brushes are helpful in cleaning the proximal surfaces. Just these. Recommendations for the oral overdentures. Now, home care for patients with an overdenture is facilitated by removing the overdenture if possible. The transmucosal abutments may be brushed with either a standard soft toothbrush or a flattened tuck brush or an interdental brush. If abutment cylinders are connected with a bar, so a floss or a flossing cord is usually inserted under the bar and then wrapped around each abutment cylinder for cleaning. Cleaning the undersurface of the prosthesis, the overdenture framework may be accomplished using a denture brush or nylon coated interdental brush. Now, I want to make something very clear here that patients usually, they do not, they're not very good with performing these these oral hygiene instructions, and it's not easy either. It's difficult for them to do it. So please do call in your patients and try to teach them proper brushing at your own clinics, so that at least they perform a proper oral hygiene regimen before their doctors at least once a day. It's a request. Please do follow this. Brushing is the easiest method to remove plaque from your mouth, and it would actually automatically add on to your implant surgery lives. So, home care recommendations and instructions, as just mentioned, they are influenced by the location, the angulations, and lengths of the transmucosal abutments, the prosthetic design, of course, the patient's oral habits, motivation, manual dexterity, and oral health. So these instructions, they have to be very, very individualistic. They depend upon the need of the patient. They depend upon who your patient is and how much time they're ready to devote to to their oral hygiene regimen. Now, after discussing these, something very important: what should be the maintenance intervals? Maintenance intervals, they are determined by several factors. First would be the amount of plaque and calculus formation. This is where your baseline readings would help you that whether the patient is more susceptible to developing high concentrations of plaque and calculus. Then the condition of the soft tissues, the status of the prosthesis will tell you whether the patient will be able to follow the oral hygiene instructions or is following the oral hygiene instructions, the patient's commitment to meticulous home care, and various health considerations of the patient, such as calculus formation cannot be helped in patients who've been detected with diabetes. And of course, we have genetic factors and many other genetic conditions. So, all the intervals, they are determined on the individual basis, taking into consideration the patient's history and present day evaluation. Everything is very important. Okay, so recommendation time frame for maintenance regimens. At the time of prosthesis placement, comprehensive oral hygiene instructions are a must. Baseline data documentation is a must. After 1 month, the patient should be evaluated. We should review their home care techniques, their calculus removal, and the coronal polish can be provided to the patient if required, depending upon how patient is taking care of his or herself. Then I also follow a 3 month evaluation program where we check the plaque buildup around the implants if there is any. So we should examination the tissues that I've just seen. We should check for the BOP, we should check the probing depths, we should check the occlusion most importantly. If the patient has a teeth grinding problem, that should be checked. Then home care reinforcement, yes, we need to remind them what was being told. We need to teach them what is to be followed. And establishment of a recall interval between 3 and 6 months, determining the current assessment. And I'm finally concluding by simply saying that implant is not a one-time procedure. We always require supportive therapy that can reduce the risk of peri-implantitis. Just as the initial treatment, non-surgical mechanical therapy would be beneficial if you feel that the mucosa is being affected. Antibiotics are strictly, they have a limited impact, but then they can be a good adjunct to your, mechanical therapy, the non-surgical mechanical therapy. Lasers, have not used much of these lasers, but they can remove early supragingival biofilm. Implantoplasty may not be performed again. they are comparatively dangerous. So they're comparative. I would not say this is risky. So one can avoid these. Regenerative treatments are something that I usually prefer because they help us in achieving re-osseointegration. Again, it could be challenging depending upon, because patients usually do not turn up on time. So, the resective and the regenerative part is usually challenging and, well, sometimes may not work. But what does work here is, the patient's at home care, which is of utmost importance. So please do encourage your patients, teach them, have a talk with them, help them and reinforce the recommendations that you've been giving them from day one so they know how to maintain their treatments, right? So, that note, thank you very much. And thank you, Dr. Ugo, for this wonderful opportunity. Thank you, everyone, for listening to me. Thank you once
All right. Thank you so much, Dr. Saluja. That was pretty powerful, very detailed. We're going to go back and review those slides. Very important slides. I have a couple questions for you, but let's see. We're going to take some questions at this time. I do have a question here. Is there no role for water flossing in implant care, especially in overdentures?
See, again, I've said that flossing and flossing cords and everything, and even water flossing, everything has a role depending upon the patient's individual needs. We don't follow water flossing that much here. We use the cords, the regular cords, and the conventional methods because that is difficult for patients to learn. But you can use water flossing. That's not really a problem. You can.
Okay, I wanted to. I'm trying to pick up a slide here. There's
Yeah.
a slide I have on. So
You want me to go to that slide?
no. It's a question on RSQ. So I know most of what happens, in terms of primary stability, So is there any role? I didn't hear you mention anything about measuring the implant stability while placing or afterwards. Is there any place for that? Do you do that regularly?
I did not get your question, Doc. Can you please repeat?
So the place for implants, like implant stability patients.
Right.
So where does one, in terms of for those who are practicing, how do they incorporate that into their daily practice in terms of in placing the implant? I noticed you mentioned necrosis of the bone as one of, in terms of what happens when you are placing
Yes,
and lead
right.
you to. So is there any place for measuring? Do you do that regularly?
Implant stability is usually that we don't see after we have. Uh, I would not suggest to move the implant before the first month of the follow-up appointment. Reason being that the implant has not undergone osseointegration. We do check that the implant has been carefully placed. So initially, we take on a baseline radiograph, and then after 1 or 2 months, once the osseointegration has begun, then we check on the implant stability. Implant stability again is a very subjective and a very individualistic procedure, and there we also have immediate implants these days. So I think that probably depends on.
Yes, so this was what I was talking about.
Yeah.
Just trying to measure. I know we don't do it regularly, but I'm just thinking. So I'm hoping that in our next couple classes where we place it on, just to be able to say, okay, what was based on the bone. 'Cause I know you not mentioned, in terms of the loading.
Yes.
Why should you not load? So you don't want to load if there's no primary, no stability. So just a way to measure it.
Yes. Okay.
Anyway.
Yeah. So as such, we don't measure it here. Again, we just simply take on the radiographic examination and we check on the implant mobility. Those two are the most important periodontal criteria that we have.
Okay. Anyway. So, but for those who are watching this is not a bad slide to take a look at. So there are different ways of measuring implant stability. I think for first time users, because sometimes you're not able to tell the quality of your bone. If you are doing it for the first time, you wouldn't really know. But a good way. There are a couple more questions here. let's see. How does failed healing abutments affect implant prognosis? So you have an implant, a healing abutment that comes off, and it is not replaced. That's go ahead.
Failed healing implant abutments, they affect the soft tissues which are surrounding the implant. They would there's a reason that they have been affected, and there are multifactorial reasons, so automatically the implant prognosis, the implant would not, live a very long life if the abutment is failed, because that would not suit the patient. And that's how I read it.
Yeah, I mean, especially in a case where you did not, it wasn't planned, in terms of use the cover screw, then you close it up that way. But if you lost it, but I think, I don't know, but if you are able to, because it's just a healing abutment, if it comes off, you try to go back and put it back in if the patient can find it as soon as possible. Another question here is that what often causes sinus formation few months after implant placement with no abnormalities seen on the radiograph?
That's what I've just mentioned, that this usually happens when a patient has developed some medical condition, or the patient is not, following the instructions properly. This is what we need to reinforce. When the pus formation occurs, and pus formation automatically is a very important clinical sign which may or may not may be associated with bone loss. Even if there is no radiographic condition, then that works for us. Probably the implant, only the soft tissue is involved, and we still have a chance to save the implant.
Okay. Another question here. At early stage of periimplantitis and non-surgical.
Sorry?
You said if at an early stage of periimplantitis, a non-surgical management is applied and the implantitis is not resolving.
Yes.
Implantoplasty be done?
Yes, implantoplasty can be done. Implantoplasty, in fact, is the next step to non-surgical debridement. See, non-surgical debridement is usually preferred for the ailing implants. But once the bone is involved, probably mechanical debridement would not suffice the purpose. And we will be needing implantoplasty. But I would still suggest not to use implantoplasty there. If the bone is involved, we should always try for the bone corrective methods instead of implantoplasty immediately. Implantoplasty tends to have a very negative effect on the implant surface. Instead, we can try for surface decontamination first.
Okay. One more question here. You said, does the time of loading have any bearing? I know you had mentioned something like that, but I'm just gonna, if you can go back to that slide.
Yes, early loading can actually lead to periimplantitis. So once the loading has to be, very perfectly done. Loading cannot be compromised there. Yes, it can go. It can actually lead to a lot of bone loss. It can affect the bone. And again, I said that again, this loading affects the occlusal, the normal occlusion of the individual. So that is one area which can lead to implant failure. Yes, we need to take care of that.
Okay. Any more questions? Just going to wait for a little bit. Thank you so much. I know it's getting late in New Delhi, but it's good to have you with us today. I'm still waiting if there's any more questions here. One second.
Tough one. Okay. Can implants be successfully delivered to patients with bruxism? This is something where we need to work on the prosthetic design, where you need to tell the patient where I think it is something that can be a little challenging, but it can be challenging for all the prostheses. Patients with night grinding habit and bruxism, they need proper maintenance, and they need they need proper guidance so that they use it. In such cases, we need to relieve certain areas so that they're not centrally meeting, and the lateral excursions, they need to be taken care of. Yes, it is a little tricky when we place implants in patients with bruxism and with many other parafunctional habits. So yes, it can lead to periimplantitis. In fact, it is one of the most common reasons for periimplantitis, so that needs to be taken care of. You need to discuss on the prosthetic design. You need to discuss on the patient's habit. I mean, we need everything. It's a complete package. So you need an entire holistic approach to, to deal with such patients or to treat such patients.
I mean, that is very awesome. We're going to be presenting on bruxism shortly in the next couple of weeks. So we will cover that. Just to add here that your patients needs an occlusal bite splints, especially after you have done your restoration, to prevent, because there's some folks who are going to break everything. Yeah, some people, anything you put there will be broken. So if you need to plan for opening the bite, using a bite splint to prevent, especially after spending so much money doing all this work, you want to try to prevent it from breaking. But thank you so much, Dr. Saluja. I don't know if we have any more questions, but we do really appreciate your presenting today. This is a powerful lecture. I'm going to try to see if I can record it, but do we have permission to record this and send to all the people who attended?
I have no problems. I hope I have been able to, live up to everybody's expectations. I was doing justice to the topic, and if you find it worthy, please go ahead. I have no objections.
Thank you so much. And going forward, we're going to talk about learning experience from dental implant clubs in Nigeria. We started doing webinars. Now we did some hands-on training. Now we have formed implant study clubs in Enugu, in Ibadan, in Lagos, in Warri, and in Port Harcourt. We want to take on the case studies from this implant series. Those who are listening to the lectures, those who are doing the hands-on training, we want to learn about their success. The folks from Enugu have taken on this, and they've placed over 30 implants on patients in the past 6 months. So we're going to do a little study on that. Thank you so much, Dr. Saluja. It was good to have you here. And let me see, I think there's a question. Yes. So
thank you so much.
Let's see what question.
Thank you so much.
Okay, yes. So it was just a thank you, you're greeting you. Thank you so much, Dr. Saluja. I really appreciate you for joining us today.
Okay. Thank you so much, sir. Thank you, everybody.
How do you say thank you in are you Hindi?
Hindi, Punjabi, everything. Okay. So we say dhanyavad in Hindi, and shukriya for thank you, and phir milenge for meeting again. So I hope to see all of you guys again for another one. Thank you so much, Dr. Ugo.
All right, phir milenge, my friend. Thank you so much. All right, you take care.
Milenge.
All right, bye-bye.
Okay, thank you.
Thanks.
Bye.
All right, like I said, for those who are joining, if you are here, if you have any questions concerning this, just let me know. If you want to be a part of the study club in your city, please send me a message. Yeah, Dr. Afolabi, I think you should form one in your area, and our Healing Hands Health Society and dental consult will be willing to support your implant clubs. And that is how folks have learned. They've watched the videos, they attended the classes, and most of them are placing their implant. Thank you so much, Dr. Mafeni Jerome. That is my professor right there. It's good to see you here. You're such a humble guy, Doctor. My Abuja plug. Abuja plug is my brother from another mother. Thank you so much. I see you, Dr. Nathan Ikimi. It's good to have you here. I just want to appreciate everyone. Dr. Joseph and Jorin, you have always attended all these classes. Dr. Palancio, Dr. Clara Iwoha, representing the Enugu, Dr. Ahmed Ismail, Dr. Akingpelu, everyone here. First Dental Consult, good to see you, Dr. Ayilara, good to see you here. And if anybody's interested, we do have, I'm going to try to go to the site right now. So we do have an opportunity to serve you with any of these products that, you can place, once you attend these webinars, do 1 or 2 hands-on sessions. We're willing to come hold your hand and get you started. This is your basic kit that you can use. The Lagos one is going to be coming for those who are subscribed. Dr. Kareem Sampson, yes, I've received your request. We have actually just been one thing or the other, but we have gotten things are coming in. We've gotten the dummy implants. and we're going to give the date for the Lagos implant class shortly. Just been different things in delaying the process, but we are on our way. We are set. We're getting some new kits, some new implants, coaxial implant kits from China. It should arrive in the next 2 weeks, and with that, we'll take on. Thank you so much, Dr. Mafeni. Anybody, if you have any question, I'll be able to sit down and just talk for a little bit before we go. So if you're interested in getting this kit here, the small kit is your best bet. I know Dr. Mafeni has the stopper kit because that one has, it's kind of graduated so that you don't go beyond what you plan. I like the stopper kit, but it's a little more expensive. The stopper kit is $2,000. The surgical kit, so sorry about our our Naira slide, but these prices remain. Yes, Dr. Ismail, if you would send me a message here, I'm going to type my email address right here. If you are interested in the Implant Study Club, just let me know where you are. If you are in Enugu, Enugu is already formed. Ibadan is ongoing. Lagos is formed. And we also, have Abuja. Dr. Uche Okoyezu, this Dr. Okoyezu is one of the, you've done amazing. I see work. So I'm looking forward to having the Enugu folks to come in and present their cases soon. Yes, the stopper kit is user-friendly, but it's more expensive. It's $2,000. The surgical kit is $700, and each implant right now is $100. So that's just the way it is. The implant parts, they're still like $15. I'm using dollars because that doesn't really change much, but our Naira goes up and down. So it all depends on, so that's why they are priced in dollars for right now. Whenever you're ready, just friend, if you are ready to get any implant training or any implant class, I'm going to put a number to our officer in Lagos, Mr. Ego, who is going to help you get started. Oh, yes. Oh, yeah. General practitioners camp. Of course, we're all mostly general practitioners in the implant club. I mean, today we are all, Dr. Okoyezu, are you able to speak a little bit? Do you have some time? I want you to just share your experience. If you are able to, first consultants, if you're willing to speak, please go ahead.
Hello, thank you, everyone.
Yes, good afternoon. Good afternoon, sir.
Good afternoon, Dr. Uvo. To the dental professionals listening who have joined the program, Dr. Uvo has taken us through all the stages and helped us start sinking implants. When we are done with all the initial kits he sent us, we asked for support services. He told us there's one around the corner. He introduced us to Dental Technologies Consult. And with their services, you can run into any issues whenever you want to sink implants. The implants are readily available, all the parts, all the various types of abutments that you need for every stage of the work. They have all the support service. And he keeps encouraging us. He set up the implant club for us in Enugu and has been assisting and encouraging us all the way. And of course, he brought this lecture our way today again to teach us one of the complications that may arise in the course of implant treatment cases and how to navigate around it.
Yes. Yeah, thank you so much, Doctor. I like the way you have taken, I'm encouraged to see how much you have done. And I'm hoping that some, in the next couple of weeks, maybe we can get photographs and just photos of all the cases that you have done in Enugu. If your implant club can come together and just present what you have done and the challenges that you faced. I noticed you were doing a lot of grafting. along with your implant placement?
Yes.
Yes.
Because we discovered that so by the time we met many of the patients, there are a lot of bone resorption.
Yes.
So we needed to do bone grafting to be able to support them, and then it turned out very well.
Do you think how was the transition? What do you think? Someone who is just starting, how long will it take for someone who is just starting to watch the videos or take a class? How long do you think it should take him if he has all these things available to be able to place his first implant?
Well, it basically would need to be taken through the hands-on session. Watching the videos alone may not be all that the person needs.
Okay.
You need the hands-on sessions, and then or have someone who has sunk a couple of implants put you through in a patient. Then that helps you with the confidence.
Yes. Yeah. Anyway, thank you so much. I'm going to put my email address again for those who want to make any contacts in terms of how to move forward with the implant club. If you want to get the parts are available. The small kits are available. The implants are available right now. So if you have a case, usually a simple case, a premolar case for the maxillary, a molar case for the mandible, will be in a good choice. Yes. 2 weekends, then it can start under supervision. I think that would Dr. Kimi, that is it, because you just have to do it. It's called dental practice. I mean, you learn this stuff, but you just have to do it. You do a couple, and before you know it, you will figure out what bone density is. If it's soft, because these things are moving pretty fast, but over time you're going to learn. And if you want to get more, please send us a message. And if you are in the dental group, obviously, you can see our WhatsApp number in our NDA group as well. Looking forward to speaking with everyone. Thank you so much for giving us part of your Sunday today. Looking forward to, like I said, we're going to come up with, we're going to have a review of our study clubs, what we have done with the study clubs. We're going to review that very soon. I'll put the advert out. So we'll just go through our journey from the dental implant study clubs, the hands-on session, the forming of the clubs, and actual placement of implants. So it has taken us a while just to be able to get there. We're going to have that presentation, and hopefully we can get Enugu to present. We can get folks from Ibadan to present, and also those who in Benin, University of Benin, obviously, they are also placing and restoring implants after a combined effort. We had help from one of our senior colleagues here in the United States. And we're looking forward to speaking more with you about how to do that. Let me see, I can pull up that information again for the all right. So the learning experiences from dental implant study clubs. Does anybody have any question, anything you want us to address as regards this? I have like another 10 minutes here. You can unmute your mic. Thank you so much, Dr. Okoyezu, for what you have added to a real life experience from these clubs and what you're doing now.
Thank you so much.
All right, thank you. So like I said, we have an opportunity to, it will guide you. I mean, some of those things, you need somebody to hold your hand. I mean, even in training, even in residency training, you get to have that. I'm hoping we can practice on wood saw jaws. We can practice on pig jaws. We're going to have a pig jaw seminar in Nigeria very soon. if you'll be interested, obviously we're going to have placing on implants on live patients. We did have that in Abuja with Dr. Ekimi assisting some of the participants in when we did it in Abuja. Yes, so for the support, I'm going to pull that up here.